Hey guys, welcome everyone to the Physics Wala Method. I'm Dr. Patil, and in this video module, primarily focused on FMGE students, we will be taking up some high yield images. I do understand that the exam is just around the corner and you don't have time for a didactic or a detailed lecture, so I will try to keep it crisp and focus on the important images that you need to know before you step into the upcoming FMGE exam. So we'll have around 10 or 11 image based questions and I won't take more than 45 minutes or 50 minutes of your time, right? So without wasting our time, let us start with the first question. What we will do is, instead of giving you options, we will have a stem, the clinical stem, and I want you to identify which disease the stem is talking about, and then we will talk a little bit about image, what we need to know from the image. Okay, so we'll start with the first stem. So in this stem we have a middle-aged woman or female who presented with difficulty to comb hair and difficulty to get up from the sitting position, right? She also has bilateral ptosis and her symptoms get worsened as the day progresses. Okay, and when we asked this lady to give a smile, she gave definitely a beautiful electric smile, but we do observe some abnormalities on her face when we asked her to smile. Okay, so now the examiner is asking you what is the diagnosis, and the second thing you should tell me is what image based finding we see in this image, or what is the name of this facial appearance that we are getting here, right? Anybody is giving me an answer in the comment? What is the diagnosis and what is our findings on this image based lesson? Veer, it is not dermatomyositis, but you're somewhat close, I appreciate. Okay, so first thing, when you say you have difficulty to comb your hair, right? So to comb my hair, right, what all muscles are involved? Most importantly, it is the muscles of your shoulder girdle, right? The deltoids, which are helping you to elevate your arm to comb. So the patient has weakness of muscles around the shoulder girdle, right? When you say get up from the sitting position, mostly your anterior thigh muscles, right, the quads, and your hip muscles or your glutes are involved in helping you get up from the sitting position. So patient probably has weakness of muscles around the shoulder joints and weakness of muscles around the hip joint. So that comes across as what we call as proximal muscle weakness. So point to note from this stem is patient has got proximal muscle weakness. And in what disorders we get proximal muscle weakness? We get proximal muscle weakness in two sets of disorders. First one is myopathies or muscle disorders. Dermatomyositis is one of them. Good evening everyone. Sachin, good evening. And the second one is when you have the disorders of neuromuscular junction. So if I have a muscle disorder like muscular dystrophy or dermatomyositis, or if I have neuromuscular junction disorders like myasthenia gravis and Lambert-Eaton myasthenic syndrome, I can experience proximal muscle weakness. Now, as I look further into this question, we notice one important finding here. What is that? She has bilateral ptosis, right? Do we get ptosis in patients with the muscle disorders? No. The second thing we notice here is that her symptoms are worsening as the day progresses. So symptoms worsening as the day progresses indicates that the patient has got what we call as diurnal variation of her symptoms. If I have Duchenne muscular dystrophy, right, I will have the same level of weakness whether it is morning, afternoon or evening. So whenever you see diurnal variation of weakness, it indicates that we are dealing with the disorder of neuromuscular junction. And what is the most common disorder of neuromuscular junction? Yes, it is myasthenia gravis. So this clinical stem is all favoring what we call as myasthenia gravis. So for this question, the diagnosis will be myasthenia gravis. Now, having recognized the disease, let us look into the observation in this image. So whenever we ask a patient with myasthenia gravis to smile, the patients with myasthenia gravis have ptosis. Apart from ptosis, they have weakness of the facial muscles. So there will be a drooping of the facial muscles. So when you ask them to smile, right, when someone gives you a smile, the first thing you will notice is that the lateral part of their mouth, right, moves upward, wide and beautiful smile. But unfortunately, these people are not able to lift it up because the muscles of facial expression are not able to contract well. So when they smile, only this portion gets lifted up, and this kind of looks like the snarling of the dog. That is why this facial appearance, as you see here, she has been asked to smile. instead of giving a wide smile, right, only a small portion of the lip is lifted up. So this finding is what we call as snarling faces. So the diagnosis is myasthenia gravis and the image observation is what we call as snarling faces. Snarling faces. Snarling is one way of expressing anger by the dogs. So if you just Google what snarling stands for, you will get to know what actually snarling stands for. Like dogs open their mouth and try to show their teeth to threaten an enemy or the opponent. So kind of similar look we are getting here. That's why we call it as snarling faces. Okay, good. Now we will move to the next question. Again, please look at the stem and then the image observation. So what is the stem? The patient has presented with fever and neck stiffness. So the moment you hear fever and neck stiffness, what should come to your mind? Whenever someone says fever and neck stiffness, what should come to your mind? Right, meningitis, right? So the diagnosis here is meningitis, and then they have given an image and asked you to identify what is this sign known as. There are two major signs that we usually try to demonstrate whenever we are suspecting meningitis. The first one is called as 𝐒𝐿 sign and the second one is Brudzinski sign. So what is this sign? So as you look into this image, you will notice that the patient is made to lie down flat on a bed, right? And then one of the limb is flexed at 90 degree at the hip and 90 degree at the knee joint, and then the examiner is trying to further extend the knee joint, right? And he is probably observing whether patient experiences pain or he feels resistance for further extension. So what is the sign is known as? Lambert-Eaton syndrome is one more neuromuscular junction disorder. So in myasthenia gravis, there are antibodies against the acetylcholine receptors, and in Lambert-Eaton syndrome, there are antibodies against the voltage-gated calcium channels. Both of them are neuromuscular disorders. Right, so this sign is 𝐒𝐿 sign. In Brudzinski sign, we ask the patient to lie down flat, right? And then we will suddenly flex the neck. On flexing the neck, there will be flexion at the hip joint and flexion at the knee joint. So if I suddenly flex the neck, right, hip will get flexed and knee will get flexed. So there will be flexion at the knee joint, there will be flexion at the hip joint. That is what we call as the Brudzinski sign. So the image here is showing 𝐒𝐿 sign. 𝐒𝐿 sign. Yes, similarly they can give you an image based question on the Brudzinski sign also. Okay, next there is an image, and as you look into the image you will notice that someone has held an instrument in his hand. It has a small thin thread or a wire and he is trying to press it against the patient's feet, right? And then they are asking you what is the name of this device and what is it used for. What is the name of this device and what is it used for? So can anybody tell me what is the name of this device? Then we will talk about what is it used for. What do you think they are trying to do here? There's a small device, right? Sometimes in some books or some exams, they may also give you a small card like this and then a filament like this. No, it is not Babinski, right? Because do we have a filament or a thread or a wire at the end of the knee hammer to do a Babinski sign? No, it is not plantar reflex. Okay, so let me tell you what is this device called as. This device is either called as Semmes Weinstein monofilament. Semmes Weinstein monofilament. It can simply also called as monofilament. Either we can call it as Semmes Weinstein monofilament or simply called as monofilament. So what this does is when we try to press against the patient's feet, right? No matter how hard you press, a fixed amount of pressure is exerted by this wire or the filament. So when you try to press, it will press after it has, like, it will buckle into a C shape after it has exerted 10 gram of pressure. After it has exerted 10 gram of pressure, it will buckle and further pressure is not transferred. So whether you can feel the 10 gram of pressure or not is what we are testing in this test, right? The device is called as Semis-Weinstein monofilament or 10-gram monofilament, and it is used, yes, it is used in patients with the peripheral neuropathy. But is it used for the diagnosis of peripheral neuropathy? The answer is no, right? Yogesh Rathi, absolutely right. It is used in patients with peripheral neuropathy. But is it used for the diagnosis of peripheral neuropathy? No, right? What is the gold standard for the diagnosis of peripheral neuropathy? That is again an important MCQ. What is the gold standard for diagnosis of peripheral neuropathy? The gold standard for diagnosis of peripheral neuropathy is what we call as nerve conduction studies. Nerve conduction studies. Then why are we using this test? Is it used for screening of the peripheral neuropathy? No. Then why are we using it? See, what is the most common cause for peripheral neuropathy? Again, one more important MCQ point. What is the most common cause for peripheral neuropathy? For peripheral neuropathy, most of us may be having a relative or a family member with a peripheral neuropathy. The most common cause for peripheral neuropathy is diabetic neuropathy or diabetes mellitus. Diabetes mellitus is the most common cause for peripheral neuropathy. Vitamin B12 deficiency can also cause, but much more common is diabetic neuropathy, right? We call the condition as diabetic neuropathy. Absolutely right. Okay, now what is the problem that these diabetic neuropathy patients are going to face in their lifetime? Most of the diabetic neuropathy patients, because they lose the ability to perceive pain, right, they sustain micro trauma, right, small injuries. Those small injuries, yes, B6 deficiency can also cause neuropathy. So the causes for neuropathy, the list is long, right, starting from nutritional deficiencies, which include most of your B complex vitamins, right, to even drugs, right? Can anybody give me an example of an antibiotic that is known to cause peripheral neuropathy that has been asked in one of the FMGE exam? Yes, so they develop what is called as diabetic ulcer or diabetic foot, right? Why are they developing? Because they're not noticing the traumas that they're experiencing. For me, if I step on a gravel, right, it hurts, I notice it, I protect my feet. Pain is a protective sensation. But if I don't feel the pain, then there is no protection, right? I injure myself more than individual who can feel the pain. And once I get an infection, injury, right, then diabetes, I don't have a good defense against infections, I get infection, and then it progresses to what is called as diabetic foot, and it might even end up in amputation, right? We know that diabetes increases the risk of amputations. So if I have to prevent all of that happening, obviously I need to definitely control diabetes, but equally I should know when the patient has no longer able to perceive the sensations sufficient enough to protect him against the trauma. Like the level at which the sensations can protect is called as the protective level, whether he has crossed that and no longer he has a protection. So this test is called, it is used for detection of loss of protective sensation. For detection of loss of protective sensation means the pain and touch sensation you have lost to the point that now your feet are no longer protected from trauma, you don't feel it. So that is a point where as a physician I refer it to a specialist called as podiatrist, who will design specialist footwear so that the foot of this individual is protected. So we call this as loss of protective sensation, or in simple words, LOPS. Again an important MCQ that has been already asked. LOPS has been asked. This image was given, not exactly the same image, but an image where there was a card used, right? They had a card and then the card had a filament at the end. So you can have different kinds of images that might appear in your exam. Just give me a second. And then there will be a filament at the end like this. So either a card with a filament or a handheld tube with a filament. The filament is the most important thing. When pressed, it exerts 10 grams of pressure, and after that it no longer exerts the pressure. A diabetic neuropathy patient who can feel this, his feet is protected against any trauma, he will be able to notice it, but if he can't feel it, then he has lost the protective sensation. Baba, I think probably 21st. Yeah. Okay, so what is this device? Semmes-Weinstein monofilament or a 10 gram monofilament used for detection of loss of protective sensation in patients with peripheral neuropathy, and diabetic neuropathy is the most common. Diabetic neuropathy is the most common cause for peripheral neuropathy. I asked you one question, right? Name an antibiotic which is known to cause peripheral neuropathy. An antibiotic which is known to cause peripheral neuropathy, right? Can anybody give me an answer? Isoniazid, yes. Other than that, see, isoniazid, we know the mechanism, right? But there is an antibiotic whose mechanism we don't know, but yes, it is known to cause peripheral neuropathy. Fluoroquinolones, they can cause, but quite rare. More likely they affect the muscles and tendons, right? They cause muscle dysfunction and tendon rupture. Isoniazid, yes. Okay. Many of you may not be aware of it, but metronidazole has been implicated pretty strongly in causing peripheral neuropathy. That is why nowadays when we give metronidazole, right, we give it only for short period of time. In the past, for amoebiasis and various other, like especially amoebic liver abscess and all, we used to use it for a very long period of time, and many of those patients used to end up developing some degree of peripheral neuropathy. Okay. Now we will move to the next question. So here there is a sign given in the image. Two questions are being asked on this. What is the name of the sign and in which disorder it is seen? I will give you clues if you are not able to identify, but pay attention to the image and see what is happening here. Let me draw your attention, right? Look here and look here and look at my hands, right? What is happening here? Look at my dinar eminence. Look at this dinar eminence, right? And on the dorsal side of this. So what we notice here is there is atrophy of the dinar eminence, right? Atrophy of the dinar eminence. Okay. So in what conditions we can see? Let me go on giving you some clues. So I have seen a patient who was slightly elderly. He presented to me with weakness of different body parts or different limbs, and when I examined him, I saw that some areas of his body or some muscle groups were showing increased deep tendon reflexes and hypertonia, and some areas of his body were showing decreased deep tendon reflexes and hypotonia. That's a clue. So now think of it. Yes, dinar atrophy, C8, absolutely right. Good. But I'm building a case against around this image, right? So the story goes like this, right? Or the clinical vignette goes like this. Complaint of the patient is that patient is experiencing multiple body part weakness. Okay. And on examination, what do we find? On examination, some muscles of his body part are showing increase in deep tendon reflexes and hypertonia, increased muscle tone, and some muscles in his body are showing decreased deep tendon reflexes and hypotonia. So now what disease should come to your mind? This is a very classical story. Some muscles showing hypertonia, exaggerated deep tendon reflexes, some muscles showing diminished deep tendon reflexes and hypotonia. Any question you get this, what should come to your mind? Good. So when deep tendon reflexes are exaggerated and we have hypertonia, what does that indicate? I think someone pointed out, right? It indicates that there is Sachin Rajput, absolutely right. So it indicates that there is damage to upper motor neuron. So it indicates that there is a upper motor neuron lesion. There is a upper motor neuron lesion. And when there is decreased deep tendon reflexes and hypotonia, what does that indicate? it indicates that there is a lower motor neuron damage or lower motor neuron lesion. So now tell me, in what disorder you get upper and lower motor neuron damages together? See, I'll tell you what is this upper and lower motor neuron for those who are not familiar. See, normally from the motor cortex of the brain, we have a neuron, right, which comes all the way to the spinal cord, and from the spinal cord, another motor neuron takes the information to the neuromuscular junction for us to contract a muscle. So the one that is starting in the cortex and coming all the way to the spinal cord is called as upper motor neuron, and the one that starts from the spinal cord and goes to the neuromuscular junction is what we call as lower motor neuron, right? So typically I can have the damage to lower motor neuron mainly in peripheral neuropathies. Peripheral nerves is what these lower motor neurons are traveling through, right? If I have damage to the spinal cord, brainstem or the motor cortex, I can have the damage to upper motor neuron. But there are a set of disorders where upper as well as lower motor neurons get degenerated. They get degenerated. So Tapasamantha, yes, absolutely right. So there are degenerative disorders where upper and lower motor neurons get degenerated. Okay. So if you haven't got this clue sufficiently, I will give you the best possible clue. This is a disease which Stephen Hawking was suffering from. So now tell me what disease I am talking about. What disease I am talking about? Not multiple sclerosis. Stephen Hawking was not suffering from multiple sclerosis. Yes, it is called as ALS, amyotrophic lateral sclerosis. See, in the name only, lot of information is there. Name is amyotrophic lateral sclerosis. Okay. So when you say lateral, what lateral we are referring to? We are referring to lateral corticospinal tract, right? When you say corticospinal, what neurons you will find there? Cortex to spinal cord. It is mostly motor neuron, right? Sensory neurons are all going up. The one that is coming from the cortex to the spinal cord is going to be a motor neuron. So it is a motor neuron, and as we just learned that from from the cortex to the spinal cord, it is going to be upper motor neuron, right? So when I say lateral, I am referring to lateral corticospinal tract. That means I am indicating that there is degeneration of the upper motor neuron. And then the name of the disease says amyotrophy, or in other words, atrophy. Atrophy, right? Atrophy indicates what? Atrophy primarily indicates damage to lower motor neuron. So a disorder where there is degeneration of upper as well as lower motor neuron is what we have called as amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis. Okay, so the diagnosis I have already given you. This is amyotrophic lateral sclerosis. And the name of the sign is called as split hand sign. Split hand sign, because of the atrophy of the thenar muscles. Now, right, I will not be able to oppose the thumb against the other fingers because of the atrophy of the thenar muscles. So now it is like the hand has been split into two parts. They can never come together. That's why it is called as split hand sign. Okay, cool. Okay. Now we will go to the next question. This is a question which is founded in cardiology. So here we have a 30-year-old who had sudden death while exercising in the gym, and they have given the autopsy image of the heart. What is the diagnosis? Sachin Rajput, absolutely right. Now I have few questions to address. Okay. Now, why this patient suddenly died while exercising, and what are the image findings? Right, I think most of you got the answer right, because this image is very famous. Because when FMGE puts, like in FMGE as well as NEET PG, this image has directly appeared because this is the most easily downloadable image from the internet, and our boards also download it from the internet itself. Banana, not banana leaf. It's a proper banana only, right? It is the banana shaped left ventricle. So what is the diagnosis here, as I've already told you, the diagnosis will be hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy, or HOCM. Okay, now can anybody tell me what all observations we see? Yes, we saw that there is a banana shaped ventricle. So basically what happens in hypertrophic obstructive cardiomyopathy is, normally muscles develop hypertrophy when we challenge them with extra work which they are not capable of, right? When we go to gym and lift weights beyond our capabilities, muscles start developing hypertrophy, right? So if I have hypertension, let me say I have hypertension and my peripheral arteries are constricted because of hypertension. Now to forcefully push the blood against it, ventricle needs to do more work and it can develop hypertrophy. That is why hypertension is the most common cause for left ventricular hypertrophy. Or if I have a aortic valve stenosis, right, this opening is very narrow, then left ventricle has to do a lot of work, and then because of that increased work, left ventricle can develop hypertrophy. But some individuals are born with genetic mutations which makes their left ventricle grow without any reason. There is no mechanical challenge to the ventricle against which it is working out and developing hypertrophy. It is like we don't go to the gym but still end up becoming muscular. So these patients, left ventricle develops hypertrophy without a reason because they have genetic abnormalities. Okay, so what happens when left ventricle develops hypertrophy? It does not develop a uniform hypertrophy. Let me say this is the left ventricle. Normally left ventricle has a conical shape, right? And this is the right ventricle. Whatever we have in the middle is the interventricular septum, right? And as we know, the left ventricle ejects its blood into the aorta. This is where I have the left atrium. Okay, so if this is the left ventricle, normally this is how it is supposed to look. And if it develops a proper uniform hypertrophy that we see in patients with hypertension and all, this is how the ventricular muscle mass will increase in thickness. Okay, so the integrity or shape of the left ventricular cavity is not disturbed. But in patients with hypertrophic obstructive cardiomyopathy, left ventricle to hypertrophy develop karegi, but this interventricular septum develops asymmetric hypertrophy. Means it does not uniformly become thick, right? From here to here, it does not uniformly become thick. It bulges into the ventricular cavity. So now my left ventricle has become ununiformly, the interventricular septum has ununiformly become thick. This is where I have the aortic valve. Now when I look at the shape of this left ventricle, this kind of looks like the banana. This is what is called as banana shaped left ventricle. And now whatever blood that is there in this part of the left ventricle, right, will it be easily ejected into the aorta? No. This asymmetric interventricular septal hypertrophy is creating the obstruction to the flow of blood from left ventricle to aorta. That is why it is called as hypertrophic obstructive cardiomyopathy. So the first observation, look into this. This is the interventricular septum which has become asymmetrically hypertrophied. This is the free wall of the left ventricle which has become hypertrophied. And now you can easily imagine a banana inside this ventricle, right? It almost looks like a banana. That is why it is called as banana shaped left ventricle. This is our banana shaped left ventricle. So the first observation is banana shaped left ventricle. Then the second observation is asymmetric septal hypertrophy. Asymmetric septal hypertrophy. Asymmetric septal hypertrophy. Okay. Now what could be the cause for sudden death while exercising in these patients? Free wall means, see, left ventricle has one wall which is shared with the right ventricle. That is our interventricular septum, right? Then it has the rest of the left ventricle which it does not share with anyone. 𝐒𝐿𝐻𝐿𝐻𝐿 hai, right? That is its free wall. So this part is what we call as the free wall of the left ventricle, and this wall of the left ventricle is shared with the right ventricle. That's why it's called as interventricular septum. Why these patients die suddenly? So please remember, hypertrophic cardiomyopathy is the most common cause for sudden cardiac death it is the most common cause for sudden cardiac death in young individuals and athletes. Young individuals and athletes. young individuals and athletes. Okay, got it. But why are they dying? Especially there is a relationship with gym or exercise, physical activity or gym. Most of these people go to some sports or gym, and then during gym activity or during the play or soon after the exercise, they collapse and die. It is not ischemia. That's a misconception. It is not the ischemia. What happens is, yes, it is the ventricular arrhythmia. This left ventricle, which is hypertrophied, is prone for ventricular tachycardia and ventricular fibrillation. It just needs a little bit of stimulus to start the arrhythmia, and that stimulus comes from adrenaline. And during exercise or sports, obviously our adrenaline peaks. So exercise or sports gives that peak of adrenaline required to push your ventricle to get into a ventricular tachycardia or ventricular fibrillation. So this is usually due to ventricular tachycardia or ventricular fibrillation. Okay. So if I have to prevent this patient from dying because of ventricular fibrillation or ventricular tachycardia, right? How can I treat? How can I prevent? Shubham Ghai, yes, there is a reduced cardiac output, so that's why hypertrophic obstructive cardiomyopathy is also called as subvalvular aortic stenosis. Means just beneath, this is the aortic wall, just beneath that the obstruction is created. That's why it's also called as subvalvular aortic stenosis. Okay, but most of these individuals will not experience major syncopal episodes or the ischemia, because their ventricle is hypertrophied and it is able to see. Please remember, in patients with hypertrophic obstructive cardiomyopathy, they have increased ejection fraction. So one way you are creating an obstruction, but this increased muscle mass will be able to forcefully push the blood against this obstruction, and majority of the patients they are asymptomatic and unrecognized. So only few percent of the patients develop syncopes as the symptom. And you're lucky if you develop syncope as a symptom, because you go to the hospital, get evaluated, doctor recognizes and it treated. Otherwise, most other patients are unaware that they have hypertrophic obstructive cardiomyopathy. VT refers to ventricular tachycardia and VF refers to ventricular fibrillation. Prevention, yes, treatment of any arrhythmia is a different ball game, right? Depending on whether patient is hemodynamically stable or unstable, we have to decide whether to give shock or drugs. But first thing is prevention. I've already told you, right, what is the link between exercise and the development of arrhythmia. What is the link? Yes, Yogesh Rati, that is an absolutely important point. These patients should avoid vigorous exertion. Good point. These patients should avoid vigorous exertion, because exertion puts them at a risk of developing arrhythmias. Yes, adrenaline is a link. Can I block adrenaline? Adrenaline's action on the myocardium. Is it possible to block the adrenaline's actions on the myocardium? We have drugs to block, right? Adrenaline acts through which receptors? Adrenal receptors, right? You are familiar with alpha, beta receptors. So can I block it? Yes, possible. So beta blockers are the drug of choice for prevention. They are considered as the drug of choice for prevention of sudden cardiac death, or VT or VF. Drug of choice for prevention of VT or VF. Okay, but what if a patient develops a VT or VF despite being on beta blockers? What can I do? See, adrenaline is a myocardial stimulant, right? We know that adrenaline will go and stimulate all the myocardial cells. Now here, because of the hypertrophy, the muscle is already prone to develop an arrhythmia. And once the adrenaline comes and stimulates, right, its rate of firing increases and we get into a VT or VF. Now DC shock or that depends on, once we develop an arrhythmia, how do we treat that arrhythmia? Treatment of VT or VF, whether it happens in a patient with hypertrophic obstructive cardiomyopathy or any other individual, is not different. Any VT or VF, we treat it the same way. I am talking about prevention now. See, I got a patient with hypertrophic cardiomyopathy and I know that he is at risk of sudden cardiac death because of the VT or VF. So I told him don't do vigorous physical activities, and I started him on beta blockers, right? But for adrenaline, that is not the only stimulus. right? When you get scared, stressed, also your adrenaline shoots up. So exertion induced adrenaline spike I could reduce by asking him not to do exertion. But if he hears a bad news or he gets scared after seeing a snake, that adrenaline can also be able to stimulate the arrhythmia. For that defense, I have given beta blockers, but if beta blockers fail and he still develops a VT or VF, this time, okay, he comes to hospital, maybe he gets recognized and someone is able to shock him or give the appropriate drugs and save. But what if it happens next time and there is nobody around to handle him? What to do? How can I prevent? So please remember, this can be a clinical question, right? Preventive measure of choice after, no, not aspirin, after a documented episode of VT or VF is what we call as implantable cardioverter defibrillator or ICD. Means beta blockers are not able to save you. The best thing we can do is shock if you develop a VT or VF. Obviously, nobody can run behind the patient with a defibrillator all along the time, right? So instead what we do is we will implant a defibrillator in the patient's body. So this will have a sensor in your heart, recognize that, oh, this patient is developing a VT. The moment it recognizes, it gives the shock to the heart. So the patient's defibrillator is now in his own body. So if beta blockers fail, that is the next best step. Okay. I think some of you were commenting about the cause, right? The cause for hypertrophic cardiomyopathy is mutation in beta myosin heavy chain gene. Beta myosin heavy chain gene. The titin mutation usually leads to dilated cardiomyopathy. Sutapa Samantha, tomorrow we have a dedicated video module where we are discussing syncope, its causes and approach. Okay, so mutation in beta myosin heavy chain gene is the cause for developing hypertrophic cardiomyopathy. And I think someone was talking to me about the reduced cardiac output. So if the obstructive symptoms are there, patient is experiencing syncopal episodes, then this obstruction can be relieved. How can we relieve the obstruction? Either we can surgically cut this part of the interventricular septum which is contributing to the obstruction. In that case, we call it as septal myomectomy. Myo means muscle, ectomy means removal. Septal myomectomy. Or alternatively, what we can do is we can inject alcohol into this part, right? We know that alcohol is bad for the heart. Many of us think that when our heart is in pain because of rejection, right, or being cheated by the girlfriend, heart is in bad shape and alcohol heals it. No, alcohol is toxic to heart, and if I inject alcohol into this part, that it will cause atrophy of this region. So either we can do alcoholic ablation or septal myomectomy. Yes, so the septal ablation or septal myomectomy is not required for those patients who do not have obstructive symptoms. Obstructive symptoms in the form of syncope, right? Or other symptoms of reduced cardiac output, hypotension. If those symptoms are there, then we need to take care of this obstruction. Yes, we can do septal ablation or septal myomectomy. Okay, good. Now here is our next question. A chronic smoker with shortness of breath. What is the sign shown in this image? A chronic smoker with shortness of breath. Alcohol, at least I would say that, okay, for first few days after a major heartbreak, it has saved lives. But after that, if you take into addiction, then it will also take your life later. Okay, what is the sign shown? There is an arrow mark pointing towards something, right? I think all of you can see that there is pigmentation on the thighs. History given is that here is a patient with a chronic smoking and this is a finding. So what do you think is the diagnosis and what sign is being shown here? Right, so please remember, most important outcome of long-standing smoking is 2, right? So chronic smoking is associated with increased risk of COPD and increased risk of COPD and CA, carcinoma of the lungs. Carcinoma of the lungs, right? Typically, when you have more than 15 pack years of smoking, you develop COPD, and when you have more than 30 pack years of smoking, you can develop carcinoma of the lung. Okay. In COPD, we know that there are two subcomponents. One of them is called as emphysema. The other one is chronic bronchitis, right? What is emphysema? Emphysema refers to irreversible dilatation of the acini, or in simple words, alveoli. So once alveoli dilate irreversibly, the air that goes in gets trapped there. Means more and more air is getting accumulated in dilated alveoli. So patient will have difficulty to exhale. It's relatively easy to take an inspiration, but difficulty to exhale. Yeah, the larger emphysematous regions can develop bullae. The bullae can rupture and cause pneumothorax. Yes, that's also there. Okay, so now the patient has difficulty to exhale. To make it easy for him to exhale, he makes certain adaptations. So one of the adaptation is, whenever you go to any patient with the COPD, right, in your wards, the first thing you will notice is that they don't lie flat like this comfortably. They're always sitting and leaning forward. It makes it a bit easier for them to exhale. Second thing, they will purse the lip, right? So when they breathe, a COPD patient, when you see them breathing, they are breathing like this. This is what we call as pursed lip breathing, right? Pursed lip breathing. And this position where they are sitting, leaning forward, and their elbows are resting on the thighs. What is it called as? COPD leads to emphysema, and these emphysema patients often have pursed lip breathing, and this position where they are resting their elbows on their thighs and leaning forward is called as tripod position. Okay. Now, if my elbows are repeatedly touching my thighs, obviously thighs will develop hyperpigmentation, right? Chronic microtraumas can cause skin to develop hyperpigmentation. Just to give you an example, you keep rubbing your nose like this, the tip becomes dark, right? You might have seen many patients coming to ENT OPD with dark tip of the nose because they have this seasonal allergic rhinitis, right? If they keep rubbing, they will develop pigmentation, right? If you have a pimple and you keep touching that area, that will become hyperpigmented. So if I keep resting my elbows constantly on my thighs, the areas where I'm keeping my elbows will develop hyperpigmentation. See, just to give you an example, I've been teaching for quite some time now, and most of the times my position is that, okay, I'm on a table and teaching all of you. So my elbows rest on the table. So slight hyperpigmentation, my elbows have developed, right? So same way here, elbows are resting on the patient's thighs. So thighs will develop hyperpigmentation, and when the thighs develop hyperpigmentation, this sign is called as Dahl sign. Dahl sign. So that is another finding that you should be aware of in a patient with COPD. So this image is showing what we call as Dahl sign. Yes, a patient with emphysema often need to use the accessory muscles of respiration when it is especially severe. Okay. Now the next term is important. Here we have a middle-aged female with cough. The complaint is cough. Pawan Kumar, we will be doing a separate neuro rapid revision session. I think day after tomorrow it is scheduled. I will quickly cover all the important topics from the neurology that you need to remember for the exam. Okay. So here we have a middle-aged female who presented with complaints of cough, and her serum ACE levels are elevated and she has hypercalcemia. Asking what is the diagnosis, and there are two images. I think someone has commented it right. Pawan Kumar says panda sign. Absolutely right. Second, what is this facial appearance called as? I think most of you got the diagnosis right. Every clue required for the diagnosis of sarcoidosis is there. Panda sign, good. What is this facial appearance called? Yes, it is called as lupus pernio. Right? Why is it called as lupus pernio? Because we have something called as systemic lupus erythematosus, where we get this classical butterfly shaped malar rash with the nasolabial fold sparing. This rash is also kind of similar. That is why the term lupus comes into picture. But here it is not because of SLE, but rather because of the sarcoidosis, right? That's why we use the term pernio. So the basic difference between this and SLE is SLE rash is not a palpable rash. It is only visible. You can't feel the difference between the rashed area and the surrounding area. But in sarcoidosis, it is a palpable rash. You can feel the induration of this rashed region. When you look at that image only, you can notice that it is a bit thickened, right? If you run your finger, you can feel the induration. Okay. Now, why we have this induration? Why this rash is palpable? What is sarcoidosis? Yes, plus yes. In SLE, you will have the photosensitivity. This is not a photosensitive rash in sarcoidosis. Yes, so the diagnosis is right. We could spot that there is a panda sign image and lupus pernio. So this diagnosis is sarcoidosis, right? What is sarcoidosis? Sarcoidosis is a granulomatous multisystem disorder, just like tuberculosis, right? Sarcoidosis is a granulomatous multisystem disorder. Granulomatous multisystem disorder. The only difference between this and tuberculosis, see, this is, when I say multisystem, multiple organs are affected, but most commonly affected organ is respiratory system only, right? Just like TB. So that is why this patient is presenting with cough, because she has developed granulomas in her lungs and the lymph nodes. The only difference is that the granulomas that we see here are non-caseating. In tuberculosis, they are going to be caseating. These are non-caseating. In TB, they will be caseating granulomas. Okay. Now, because of these granulomas formed in the lungs, patient has developed cough. Because these granulomas are also formed in the skin, right? That is why she has developed this lupus pernio. And because underneath this visible hyperemia, there are granulomas, this area is indurated and it is palpable. Yes, so inside the respiratory system, patients develop, as you mentioned, bilateral hilar lymphadenopathy. That is the first stage of sarcoidosis. Then it will go on to involve the lung parenchymal granulomas. Eventually, it can lead to interstitial lung disease. That's the last stage of the sarcoidosis of the lungs. Okay. Similarly, the granulomas also happen in your orbital region, right? In your salivary glands and in your nasopharyngeal lymph nodes. So when I do a nuclear scan to look at the activity of these regions, obviously the nasopharynx, orbits and the salivary glands will show increased tracer uptake, and this appearance kind of looks like the face of the panda, and that is why we call it as panda sign. That's why it is called as panda sign. Okay, so understood. Diagnosis is clear, the images are clear, but there are two more points to address here. These are actually examiner's clues. Whenever in a question they mention that serum AC levels are increased, first thing that should come to your mind is examiner is talking about sarcoidosis. Okay. Now, why serum AC levels are increased in a patient with sarcoidosis? Oh yes, most commonly involved is parotid salivary glands. Yes. So why there is increase in serum ACE levels? Why increase in serum AC levels, right? Which organ produces ACE? Which organ produces ACE? Yeah, it is part of the RAS system, but which organ, right? It is the lungs which produce the angiotensin converting enzymes, right? And presence of the granulomas are formed by macrophages, right? Macrophages stimulate increased production of ACE, and that is why the serum ACE levels will be elevated in sarcoidosis. That's a very important diagnostic clue. Another point here is that there is hypercalcemia, right? Why there is hypercalcemia? Why there is hypercalcemia? Hypercalcemia is because, see, we have an active form of vitamin D, that is 125 dihydroxycholecalciferol, right? 125 dihydroxycholecalciferol, which is an active form of vitamin D, right? So this conversion of inactive or monohydroxy or single hydroxy cholecalciferol to dihydroxycholecalciferol, right? It is done by hydroxylase enzyme, which macrophages can also secrete. Macrophages secrete a hydroxylase enzyme which converts inactive or not the active form of vitamin D to the active form of vitamin D, and this active form of vitamin D will increase the calcium reabsorption in the kidneys, and also it will stimulate increased calcium absorption from the gut. Increased calcium absorption from gut. So because of this increased calcium absorption from your GIT and from the kidneys, your calcium levels are increasing. Why this is happening? Because the macrophages which are forming the granulomas are stimulating conversion of inactive vitamin D to active form of vitamin D. That is why we have hypercalcemia. So just remember, any question which says some respiratory complaints, elevated ACE levels and hypercalcemia, think of sarcoidosis. Please go through images of other images of the sarcoidosis. Like there is also one more sign called as lambda sign that can also be asked as an image based question. Okay. Now coming to the next question. A 30-year-old who collapsed suddenly and became unresponsive. This patient's BP is not recordable, pulse is not felt, the ECG is given below, and there are few points to address here. What is the next best step in the management and what is the diagnosis? First, obviously, I want you to address what is the diagnosis, and then Shubham, there is no need for calcium mimetics in these patients, because once you start treating the sarcoidosis with steroids, right, the macrophage activity will come down, the granulomas will start regressing, and as the granulomas start regressing, the macrophage number is decreased, their activity is decreased, the activation of inactive to active vitamin D will come down, and the calcium level will normalize itself. Okay, so what is the diagnosis? Let me show you the image with more clarity. So almost like arrhythmias are the most important ECG topics, right? Rest of the ECG things are really not important. Arrhythmias are the most important. So what is the diagnosis here? Okay, so whenever we have an arrhythmia, right, what is the first step approach to a patient with arrhythmia? If you have a patient whose rhythm is gone for a toss, you have an arrhythmia. To be more precise, we have a tachyarrhythmia. What is the first thing that you will see on the ECG? Right, we have to look for the QRS duration, right, whether it is normal or increased. The first thing we should see is the QRS duration. The first thing you have to see is the QRS duration, not the P wave rate or anything. First thing is QRS duration. So now look at this patient's ECG and tell me whether the QRS duration is normal or increased. Let me draw your attention, right? This is the QRS duration. नॉर्मल लगता है या इंक्रीज्ड है? व्हाट इज द नॉर्मल QRS ड्यूरेशन? Normal QRS duration is less than 120 milliseconds. On an average, it is 80 to 110 milliseconds. In all cases, it is less than 110 milliseconds. तो यहाँ पे कितना है? When you look more closely, how much do you think it is? Right. So from here to here, how much is it? It looks like there are around 3 or slightly more than 3 small squares, right, from here to here or from here to here. So it is more than 120 milliseconds, right? In the examination hall, you don't need to calculate. All you need to do is from one beginning of the Q to the end of QRS, whether it is taking 3 small squares or more, because we know that 1 small square is equal to 40 milliseconds. So if it is more than 3 small squares, done. Don't need to specifically calculate. So this has more than 3 small squares. So the normal QRS duration is less than 120 milliseconds. So if it is less than 120 millisecond, right, less than 120 milliseconds, which means less than 3 small squares, we will call such condition as narrow complex tachyarrhythmia. Narrow complex tachyarrhythmia. And if it is more than 120 milliseconds, we will call it as wide complex tachyarrhythmia, right? More than 3 small squares, we will call it as wide complex tachyarrhythmia. So this patient, as we have understood so far, has got a wide complex tachyarrhythmia. Okay. Now once we have the wide complex tachyarrhythmia, next thing what we should see is how these waveforms appear and what is the QRS amplitude. Okay. So whether all the QRS waveforms in a given lead, I am repeating my point again, I am saying given lead means in one lead, because in normal ECG itself, QRS complex look different in different leads. So you can't say that, okay sir, QRS complex in lead 1 doesn't look like the QRS complex in lead V6, वो तो normal सी है. किसी भी एक lead को पकड़ो and then see whether the QRS complexes look same there or they are different. So when I take, let me say if I take V1, right? In the V1 all the QRS complexes look the same or they are different? They are different, right? Amplitude is varying, morphologically they look different. If they look same, the diagnosis is pretty simple. So you have to see the QRS morphology after this. QRS morphology. Okay. So if the QRS morphology is same in a given lead, then our diagnosis is pretty simple. We call that condition as monomorphic ventricular tachycardia, monomorphic VT. And if they are varying, then we are left with two possibilities. If they are varying, we are left with two possibilities. What are the possibilities? One of them is going to be polymorphic VT, ventricular tachycardia itself, but varying QRS morphology, we will call it as polymorphic VT. And the second possibility is it could be ventricular fibrillation, ventricular fibrillation, ventricular fibrillation. Okay. Now going back to the image, we have agreed that this is a wide complex tachycardia. So हमारे पास सिर्फ 3 ही differential diagnosis है, एक ventricular tachycardia monomorphic, ventricular tachycardia polymorphic and ventricular fibrillation. Looking at the image, what can we confidently rule out as of now? We just agreed that the QRS complexes don't look the same, right? This complex looks different from this complex, right? This complex looks different from this complex. So they don't look same in any lead, right? Take one lead and look at the QRS complex, they're all different. So one thing we can confidently rule out is the monomorphic ventricular tachycardia. That is out. Monomorphic VT is ruled out. We are left with only two possibilities, a polymorphic VT and a ventricular fibrillation, right? So I will give you the brief sketches of how monomorphic VT looks like. The monomorphic VT will look like wide QRS complexes all looking same. Please ignore my sketching skills. They may look little different because I am not a fine artist, but this is how the monomorphic VT will look like. Okay. And then polymorphic VT, the QRS will be wide, but they will be looking different. That is the polymorphic VT. QRS complexes are wide, but they are looking different in the same lead. Okay. Then the ventricular fibrillation will look somewhat like this. So when you look at the second and third tracings, right, what difference you notice? Here also QRS complexes are wide and their amplitude is varying. It is not same, right? It is not constant like in monomorphic VT. So this is kind of similar to polymorphic VT. So then what is the difference? The main difference is the QRS amplitude. In polymorphic VT, the QRS amplitude appears normal. The QRS amplitude appears normal. When the amplitude is too small, then we call it as ventricular fibrillation, right? Then we call it as ventricular fibrillation or VF. See, what is the meaning of ventricular? What is the meaning of fibrillation? Fibrillation refers to a chamber of the heart, like you might have heard about atrial fibrillation. What is the meaning of atrial fibrillation? Atria is not able to contract. It is merely shaking or vibrating. Fibrillation refers to vibration or shaking, not enough strength to contract. When we say ventricular fibrillation, means ventricle is not able to contract, it is merely shaking. Why is it not able to contract? Because the electrical impulse delivered to it, right, for its depolarization are not of sufficient amplitude for it to be able to contract. That is why whatever little bit electricity that it is getting, it is only shaking or vibrating. That is why the amplitude will be smaller. So in simple words, I could say polymorphic VT, right? Polymorphic VT, when its amplitude is shrunken small, this kind of appears like ventricular fibrillation. So the difference between polymorphic VT and ventricular fibrillation is the amplitude. It is the amplitude. Okay, I will show you an image if I have. So this is a patient with wide QRS complex tachycardia, right? And when you look at the QRS, it is wide, and take any lead, all the QRS complexes look same. So this is what we call as monomorphic VT. Mono means single, morphic means we're talking about the appearance or morphology of the QRS complexes. They all look same, right? That is why it is called as monomorphic VT. When you look at the second image, what do you notice? Amplitude wise, this also appears normal, right? The amplitude is not small. This also appears normal. But the change is the morphology of the QRS complexes varies in any given lead, right? It is not same. So then this is a polymorphic VT. Polymorphic VT, the amplitude is normal. But when you look at this bottom image, the amplitude is very small, right? Amplitude is small amplitude and varying morphology. This is what we call as ventricular fibrillation. So in the image we have the ventricular fibrillation. So it is a wide complex tachycardia with varying QR morphology, varying QRS morphology, and low amplitude. So all of this points towards ventricular fibrillation as the diagnosis. So the diagnosis here is ventricular fibrillation. Okay. Now coming to the question proper. The question is, what is the next best step in the management? Right? Look at the question. What it says, the patient collapsed suddenly and became unresponsive. The BP is not recordable, pulse not felt, ECG is given below. What is the next best step in the management? Yeah, I will come to torsities depointis also. What is the next best step in the management? So how do we manage a patient with wide complex tachycardias? Right, just few points on the management of wide complex tachyarrhythmias. Management of wide complex tachyarrhythmias. So whenever we have a patient with wide complex tachyarrhythmias, obviously what kind of arrhythmia it is does matter, whether it is ventricular tachycardia or ventricular fibrillation. Right, ventricular tachycardia, and whether this ventricular tachycardia is with pulse or whether it is ventricular tachycardia without pulse. Okay, if it is a ventricular tachycardia with pulse, whether it is monomorphic, polymorphic, does not make a difference. If it is a ventricular tachycardia and I can feel the patient's pulse, means what? Ventricles are contracting at high rate, but still they are contracting sufficiently to push the blood to circulation. So आपके brain को तो blood मिल रहा है, बस arrhythmia से आपको बाहर निकाल रहा है. So in that case, what we should do is we should look at the BP of the person. If it is less than 90/60 or whether it is more than 90/60. If it is more than 90/60, मतलब patient stable है hemodynamically, we don't need to do anything aggressive. We go for the pharmacotherapy, means give the drugs. Pharmacotherapy, right? And what is the drug of choice for ventricular tachycardia? Yes, as of now, the current drug of choice is amiodarone. Alternatively, we can consider lignocaine. Alternative is lignocaine. And if the BP is less than 90/60, we need to give shock. Any arrhythmia when BP is less than 90/60 or not recordable, shock is the treatment, no role of drugs. The two types of shock, as we know, one is called as cardioversion, the other one is called as defibrillation. So for a VT with pulse, please again pay attention. For VT with pulse, we do cardioversion. Shubhabhai, that concept is slightly moving away because studies after studies in the recent times, like last couple of years, show that patient treated with amiodarone, patient treated with 𝐒𝐿-𝐄𝐝, the mortality is higher in patients treated with 𝐒𝐿-𝐄𝐝. So in today's context, we don't use it. Yeah, the yesterday's book still mentioned that if you have ischemic heart disease and then you develop VT or VF, VT, the 𝐒𝐿-𝐄𝐝 is the drug of choice. That's what the yesterday's books talk about. Today, amiodarone flat becomes the drug of choice. If there's a contraindication to amiodarone or amiodarone is not available, we lean on to 𝐒𝐿-𝐄𝐝. Okay, now coming to the matter in this case, this patient we recognize that it has ventricular fibrillation, right? Patients with ventricular fibrillation generally do not have pulse. Why they do not have pulse? Because ventricle is shaking, not contracting. How we develop the pulse? Because ventricle contracts and ejects the blood into aorta, and once the blood comes to the peripheries, we are able to feel it. So presence of pulse means ventricle is contracting sufficiently to eject the blood. But when ventricle is only shaking, right, there is no pulse. Ventricular fibrillation by default is pulseless. If VT is also severe enough, it can be without pulse. So VT without pulse and ventricular fibrillation are two more critical conditions because there is no circulation happening. So within 2-3 minutes, the patient will be brain dead because his brain is not getting the sufficient blood supply. So in such cases, right, what is the first step in the management? What is the first step in the management? If I have a patient with VT without pulse or ventricular fibrillation, the treatment of choice is defibrillation. Absolutely right. We have to shock. The treatment of choice is defibrillation. But what is the first step or the next best step? See, you don't have pulse, right? Your ventricle is not generating sufficient cardiac output. Your brain is not getting blood. What should you do now? You get the defibrillator, charge it and deliver the shock. Kam se kam charge se 5 minutes lagega, right? By the time, even if you revive the heart, brain is gone. Yes, we should immediately start CPR. So whenever you have a ventricular fibrillation or VT without pulse, start CPR, right? And then the treatment of choice. Treatment of choice is going to be defibrillation. Defibrillation. I'm just mentioning defibrillation as soon as possible. Means it will take some time for you to arrange the defibrillator, right? Tab tak CPR karte raho to keep the brain alive. Once the defibrillator is in your hand, defibrillate immediately. So in this case, right, what is the next best step? I am giving you two options: defibrillation, CPR. Look at the patient's story. 30-year collapse suddenly, became unresponsive, BP is not recordable, pulse is not felt, ECG is ventricular fibrillation. What is the next best step? Right, the next best step will be CPR, right? CPR followed by, after the CPR, next best step will be defibrillation. Defibrillation. And see, in this question, even if I don't give you the ECG, right, what will be the next best step? Whenever someone is unresponsible and pulseless, what is the immediate reaction that a doctor should do? Unresponsive and pulseless, start CPR, right? That is a prerequisite for starting the CPR. I'm coming there. Magnesium sulfate is not required for all patients with the polymorphic VT or ventricular fibrillation. It has become the drug of choice for patients with Torsades de Pointes. So there is something called as Torsades de Pointes, which is a subtype of polymorphic VT. It's a subtype of polymorphic VT where your QRS amplitude keeps varying in such a way that it kind of looks like twisting around an axis. So it now kind of looks like a waveform. QRS in a given lead, they are not looking same. Amplitude is kind of normal. So we are going to call it as polymorphic VT. But when I look closely, it looks like a wave, that image that we used to draw during our +1, +2 in physics, right? It kind of looks like that. So this is what we call as Torsades de Pointes. Torsades de Pointes. Torsades de Pointes, as we know, is a subtype of polymorphic VT. Means it is also a polymorphic VT only, but it's a specific subtype. Subtype of polymorphic VT. This is typically seen in patients who have Most important cause, right? The underlying electrophysiological mechanism is the increase in the QT interval. If drugs, electrolyte abnormalities which cause the QT prolongation push you towards the development of Torsades de pointes, right? So can anybody give me an example for a drug which can cause QT prolongation seen in patients with QTc prolongation? I'll give you an example. Erythromycin, whole azithromycin, all the macrolides they can cause, yes. C-sapride, yes. Okay, I'll give you an example. In the recent times, right, during COVID, many people with the hope that this particular drug will prevent the COVID infection risk or reduce the COVID infection risk, they took it. And I think one anesthetist from some northeast, he also started himself on this drug. Unfortunately, he had a pre-existing QT prolongation, and then he went to bed, and next day morning he didn't wake up. Probably in the night he would have developed the Torsades de pointes, polymorphic VT, hemodynamic collapse, and he would have died. What drug am I talking? Right, hydroxychloroquine, right? Hydroxychloroquine and azithromycin. This combination with a backdrop of the wide QTc was a really deadly combination, right? Quinolones, yes, hydroxychloroquine and other quinolones, the fluoroquinolones, and along with that the quinine that we use for the treatment of malaria. All these drugs are known to cause QT prolongation. They increase your risk of developing the Torsades de pointes, right? So for Torsades de pointes, the drug of choice is, magnesium sulfate. But please remember, only when patient is hemodynamically stable. If the patient is hemodynamically unstable, you still need to defibrillate. Along with that, you can give magnesium sulfate, right? Drug of choice for Torsades de pointes is going to be magnesium sulfate, because magnesium sulfate acts as a membrane stabilizer. Okay, so I have last question up for today. Again, it's very simple and a pretty straightforward question. A patient with muscle weakness and following findings are seen. What is the diagnosis? Okay, see, to give you a simple summary of the use of antiarrhythmics, we should know the drug of choices, and there are certain specific disorders where the drug of choices get altered. So for supraventricular tachycardia, the drug of choice is adenosine, but in practice the commonly used drug is amiodarone. Okay, for ventricular tachycardia with ischemic heart disease as a backdrop, it is the lignocaine, but commonly used drug is amiodarone. For ventricular tachycardia of any other reason, the drug of choice is amiodarone, and that is what we use, right? So amiodarone, since it has come into picture, it has kind of reduced the practical use of most of the other classes of antiarrhythmics, right? So yes, absolutely right, the diagnosis is straightforward. And in fact, just looking at this description, right, one side I'm saying muscle weakness, plus I'm showing you some skin images, right? That itself tells you that skin and muscle are involved. That is what is our dermatomyositis, right? The diagnosis would be dermatomyositis. Okay, now what are these findings? The first one I think all of you are familiar with, right? What these lesions are called as. There are papular rashes that you can see here, right, on the dorsum of the hand, the papular rashes. Yes, so these papules are called as Gottron's papules. They are called as Gottron's papules. And what do you see in the bottom, right, around the eyes, you see some violet colored rash, right, violaceous rash. What do you call this as? Yes, this is called as heliotrope rash. Heliotrope rash. So both of this make the diagnosis as possibly dermatomyositis. So being a muscle disorder, these patients also develop proximal muscle weakness, difficulty to comb, difficulty to get up from sitting position. Along with that, these rashes make the diagnosis pretty clear that we have dermatomyositis. Last point before we close down, what is the treatment for a patient with dermatomyositis? Same question, they can give you that patient presented with muscle weakness, images, so you make a mental diagnosis that this is dermatomyositis, but they will ask you, how do you treat? Right? What is the treatment for dermatomyositis? So the treatment is a combination of corticosteroid. This is a autoimmune disorder. Dermatomyositis is an autoimmune disorders. So we treat them with corticosteroids plus immunosuppressants. What immunosuppressants we can use? Traditionally we have been using a drug called as azathioprine or methotrexate, or there is a drug called as mycophenolate mofetil or mycophenolic acid based drugs, or we have tacrolimus, or we can use cyclosporine. These are the drugs that we can use, right? So corticosteroids, prednisone or methylprednisolone plus immunosuppressants. Sometimes patients can have severe muscle weakness. When it is severe muscle weakness, we also can give IV immunoglobulins. So we can consider IV immunoglobulins if the patient is having severe myopathy. Okay. Now, can you give me one more example for an autoimmune muscle disorder? This is an autoimmune muscle disorder, right? One more example and then we will close today's session. I will give you a clue. This autoimmune muscle disorder is triggered by exposure to a drug. The drug is the trigger for autoimmune response. I'll give you the second clue. There's an antibody against FMGE reductase. So which drug I'm talking about? Antibodies against FMGE reductase. Polymyositis is an autoimmune muscle disorder. As an example for autoimmune muscle disorder, you're absolutely right. The difference between dermatomyositis and polymyositis is mainly in terms of clinical features. In polymyositis, there is no involvement of skin. Antibodies causing proximal muscle weakness. In dermatomyositis, antibodies causing proximal muscle weakness plus characteristic skin rashes. But the disease I'm talking about, where you have antibodies against FMGE reductase. Give me a drug which causes which acts through FMGE reductase inhibition. Which drug inhibits FMGE reductase? The drug is statin induced myositis. Statin induced myositis, which is also called as immune mediated necrotizing myositis. Right? Usually, like in these patients, there is an antibody against FMGE reductase enzyme. So we have anti-FMGE reductase antibodies. And please remember, this can be a MCQ. This is the most severe autoimmune myositis. This is the most severe autoimmune myositis. How do we treat? Stop giving the statins and give steroids and immunosuppressants for some time, right? So that's it for today on the image based session. Tomorrow, day after tomorrow, and the next day, 3 days, we have some rapid revision scheduled on the cardiovascular system, the nervous system and the respiratory system. So that will conclude our journey towards the preparation for FMGE. I wish you all the best. Stay focused, study only important and relevant topics. And I hope this time all of us will be able to sail through. See you tomorrow, guys. Till then, have a good time. Bye-bye. Bye everyone. Bye-bye. Thank you everyone.